which are the ones known to most of you, so anorexia and bulimia. Binge eating disorder is now in the DSM-5. That is not going to be a focus of today. OSFED is sort of the catch-all category for when it doesn't fit into those two. And then these are other ones just for the sake of completion that are not very common and probably not very common, certainly in the population that you guys see. So, what are eating disorders? Eating disorders are two things. The first is someone having repetitive, constant thoughts and preoccupation in their mind about weight, shape, and what they're eating. That's the first hallmark feature. The second is that becomes accompanied by unhealthy behaviors. So significant restriction for both anorexia and bulimia, and then a combination of the other ones depending on the person. So could be overexercise, binging, vomiting, using pills. The biggest thing is that this is happening for them 24/7. So if you ask someone when you're screening, which you will do after this, how often are you thinking about weight and shape? If it's in the morning when I get dressed, that's not an eating disorder. If it's constantly in their mind all day and they can't focus on their subjects and let alone not having enough nutrition to be able to focus, that's when you're starting to get into the area of an eating disorder. So how do we make a diagnosis? This is how the DSM diagnoses anorexia nervosa. And there's three things, and the first one, the most significant. So significant restriction of food leading to low body weight. And the hallmark for that is about 85% of where someone's supposed to be. So we're going to take a little path off and talk about what that means, 85%. So, show one more time. There it goes. Okay, so this is an adolescent slide. So you can see someone is following nicely. Oh, I need to stay here, along their growth curve. This is an artificial slide to show you that someone is supposed to be at 100 pounds, but they've fallen to 65 pounds. And that makes them, let's go back, sorry. 65% of where they're supposed to be. So if someone's supposed to be 100 pounds, if you lose 15 pounds, that's anorexia nervosa. That's the weight range for anorexia nervosa. The other big thing about this is someone could lose 15% of their body weight and still be in what society might say is a healthy weight. Might be in a normal BMI range, but they are lower where their body previously was. They've lost their period, they're having all the other symptoms, they've lost 15%, but visually you may not see it, and that is hugely important. And that brings up the notion of set point. Raise your hand if you know what set point is. Oh, I love seeing a few hands. So, set point is the notion, we all have a set point for height. Nobody thinks the woman on the left ate too much or that the woman on the right didn't eat enough. We just naturally know, genetically, they're at extremes in terms of a range of heights. So set point is the notion of that for weight. And somehow as a culture we struggle with that. But really, biologically, we are not all meant to be shaped the same. We're shaped dramatically different, and we have different sizes. If Miss 30F was the size of Miss 36G, it might be too much for her body's genetics, and vice versa. If 36G lost weight to 30F, she'd probably be quite unhealthy. So set point is the notion that we all start at a place where our bodies are happy to be, and menstruating for women as a result, and less than 15% is wherever that person was, is lower from where they were supposed to be. What's confusing is the World Health Organization gives us this range for a BMI, but that's for a society. That's not for any given person. So at any given person, it's much more determined of sort of where their family shape and size was and where they previously were. And just to add a little bit more information to that, this is sort of, it's becoming less counterculture, but has been for a while. There's actually very little correlation between weight and health, which is not how I was taught in medical school, and certainly not the messages that are out there. I love this slide. This is of hundreds of thousands of women in the United States, and it's the weight associated with the lowest mortality, so the least likelihood of dying. And you can see for Caucasian women of different ages, it dances around what's considered the upper range of healthy, per se. And for African American women, it's already in what's considered overweight. Big picture, we need to reclassify those weight ranges, because this is actually potentially quite healthy for them. So, there we go. What is correlated to health? Activity level, absolutely, and genetics. Whether you're getting high cholesterol from your family history, or if you're inactive. And I love this picture. It's getting old now, but it's of 3 gold-winning Olympic athletes for Canada, and it shows, depending on their sport, shot put to track, what their different sizes are. There's not a chance that any of these women are unhealthy, and the woman on the far left would have a BMI in the 30s. And this lovely lady, probably went too quickly there, but I'm speeding up. You know, on the left is not often what a picture that you see of health. She could not be healthier, Serena Williams, and this is her natural, well, very active, healthy, but at her natural shape, and definitely well into the 30s for a BMI. So that is just a divergence to the notion that you need enough weight loss to be 15% lower than when you're supposed to be, and there's a range depending on the person. The next thing you need for anorexia is an intense fear of gaining weight. That's where that obsessional thinking happens there all the time. And the last thing you need is one of these 3 things. So distorted body image, which is what that picture is referring to, that's a very real phenomenon. People see themselves as up to 200% bigger than they actually are, almost like a delusion. Complete influence of weight on self-worth, and lack of insight and denial of seriousness, which is also a real phenomenon. What's taken out of the DSM is the need to lose your period for a female. That was only to broaden the category. It's a very useful clinical feature. If you're seeing someone losing weight and they've lost their period, that's malnutrition. That's when you're starting to get concerned. There you go. All right, so quick question. Individuals with anorexia nervosa do not binge or purge. True, raise your hands. False. Don't know. Excellent. So, the answer is false. People don't naturally put those things together, but there's different types of anorexia. There's one which is just the restricting of intake, and maybe over-exercise as well. And then the second type are folks who have lots of weight loss, but do have these other symptoms as well. We'll talk about these symptoms a bit more. So if someone is binge eating a large amount of food each day, and they're purging, if they're low weight, they're in the anorexia category. If they're regular weight, they may have more bulimia. So that switches us to bulimia. What do you need for bulimia? You need 2 things. One is a binge, and one is some form of compensatory behavior. So what's a binge? A binge is like someone's brain goes on a switch, and they feel complete loss of control on autopilot, and they go and find a large amount of food, I would say it's bigger than a holiday meal, in a short amount of time, like an hour or so. And that's usually carbohydrate driven. So it will probably include chips and bread or ice cream, etc. That's what the body's craving, and that's what they're driven to do. This is followed by some type of compensatory behavior. It does not need to be vomiting, which somehow gets linked. It could be just severe restriction the next day. So for bulimia, you need the binge and some form of compensatory behavior. So why does this happen? Folks who have bulimia nervosa may start off the same as folks with anorexia, significant restriction. For whatever reason, their body says, not a chance, you're not doing this to me, and it's incredibly protective, forces them to get nutrition. That ends up in the binge that's happening, their body's just scrambling for food. And then the person themselves feels, I'm not strong enough, I'm not good enough, I can't believe I did that, I should never have done that. They feel uncomfortable about the amount of food, they're terrified that they've now gained 10 pounds. And then they either have a compensatory behavior in the moment, like having a purge or vomiting, or they say, oh, tomorrow I'm going to get this right. And they wake up and they don't eat all day. So that's the classic cycle. No breakfast, no lunch, maybe minimal dinner, and then the body says, they have a binge, and then the next day it starts all over again. That is the cycle. Bulimia, you only need to have that binge and compensatory behavior one time a week, and you can't have anorexia. So again, as soon as you're low weight, you don't have bulimia anymore, you're in the anorexia category. So how common are these illnesses? That first column is what I'd focus on. In your population here, it'll be approximately 1% of females who have anorexia nervosa. Bulimia is much more common. It's 1 to 3, but now with the new definitions, it's going to be more like 5% because they've just broadened the range to make that definition. And then the catch-all category, which means, all it means is what we've artificially defined as those two illnesses doesn't capture everybody. The catch-all category is pretty significant. So a lot of folks who have that. These numbers are female only, but we know the ratio has remained 10 to 1 for the illnesses of female to male. When do they start? Anorexia nervosa is an illness of adolescence. So only 5% start after the age of 20. So that capturing it in adolescence and early is essential. Bulimia is a little older, but certainly within the age range of folks you're seeing. So that's the end of the definition. Any questions on that? Okay, so let's move to understanding the illness itself. Majority of individuals with eating disorders come from dysfunctional families. False. Don't know. Excellent. And as many of you well know, it's false. So there used to be this notion of like a meshed mom and daughter and a controlling dad. That's been completely disproven. I always say the folks we see is the same range of families as you'd see in an asthma clinic. You've got some families who are struggling, and you have families who are really managing quite well. So what does cause eating disorders? We don't know. We think of it as a perfect storm of a bunch of things coming together. What we do know is actual risk factors are listed here. So family history of an eating disorder. Anorexia nervosa is one of the most heritable illnesses, incredibly genetically driven. Interestingly, premature birth, so having low birth weight is a risk factor for developing anorexia nervosa. And then this cluster of symptoms. So I've listed pre-existing anxiety, sensitive nature, and folks who, not because of their families, but within them feel not good enough. And I would say as a result, I feel like I work with the most incredible youth on the planet. They're the nicest of kids. They feel a room, they know where there's tension. They walk in, they're like, oh, Mom had a bad day. They sense things incredibly. Which is why I have this picture. Does anyone recognize that? Yeah, so it's canary in the coal mines. They used to send canaries down in the mines because the miners couldn't tell when the oxygen levels were low. And when they were, the sensitive canaries would sort of go over, and that's when the miners knew, okay, it's time to go up. And these folks are the canaries in the mines of a fairly toxic environment in terms of focus on weight, shape, and nutrition. Just to touch on that very briefly, The number one magic wish of girls between 10 to 14 is to lose weight. Now that's American. Maybe magically that's not the case here. Probably it's still a high percentage. They're fed horrible images like this, and this is what healthy adolescents, Caucasian adolescents should look like. They're the national basketball champions. Just to remind us that this didn't always have to be the case. This is an ad from the 30s where the woman on the left says there's no need to be skinny now. I'll tell you a quick way to gain weight. And the woman on the right says, I'm so lonely and unhappy. Nobody likes a skinny girl. And it's an ad for beer. So I love this slide because really in the grand scheme of things, the 30s is not that long ago in terms of the time that we've been on the planet. And our thinking has really changed. These are more ads. These are from the 50s. This is a product called Weight On to gain weight. And just so we don't think that women are the only ones, you may recognize these two figures of Han Solo and Luke Skywalker. When they came out in the 70s, as a few souls here may remember, they were just regular guys. They're straight up and down. And over the years, the figures of them have changed. If you watch James Bond over the years, James Bond was a bit nerdy in the 60s, and he's changed as well. That whole pressure has also shifted for men as well, and photoshopping happens for men photography as well. I've pressed too hard. Oh, excellent. So, development of an eating disorder, we talked about risk factors, that the sensitive nature, we talked about toxic environment, and then there's comorbidities. So what goes with eating disorders? It's mostly for the clinicians in the room. I'm just going to put these all out. Oops, backward. Yeah. So with anorexia nervosa, basically depression and anxiety. And this is why I said for anyone you're seeing with these, you want to ask the questions, which we'll get to with 2 screening questions because they're just so mixed in. We always say that if at assessment, I haven't diagnosed an anxiety disorder, it's the notion we'll figure out what that is over time because it's just the hard wiring of someone who developed anorexia nervosa. And then these personality traits of being sort of very focused, rigid, obsessive, great traits to get through school, but maybe on overdrive. That's sort of the things that go with anorexia nervosa. And with bulimia, interestingly, the first 2 are exactly the same, high rates of depression and anxiety, but then a whole series of others that more of a chaotic person. So substance abuse, risk-taking behavior, maybe borderline personality traits, which you guys I think are having a session on later, self-harm, chaotic relationships, that type of picture. So same first 2, but then a different picture for what else goes with it. So we have this vulnerable youth. How do they actually develop an eating disorder? There's usually some kind of stressor. It does not have to be significant. And they're looking for some way to cope, and our society gives them dieting as something to turn to. And for those who develop eating disorders, we know 95% of adolescents will diet at some point, but for these ones, it starts to snowball. And the snowballing can be really reinforced. Lots of youth will say, oh, my teacher said to me, how are you doing this? I've never been able to lose weight like this. Lots of reinforcing, and I don't mean to demonize that teacher, it's a cultural norm that this seems to be a good thing to lose weight. So it's really reinforced. And then it develops into something way beyond dieting and actual illness. So what does this illness look like? Classically, we will hear parents say that I had a perfect child and never said peep, and now emotionally, they're screaming nonstop. Again, I don't mean this to be pejorative, but they talk about malnutrition, they literally become a different human being. Eating disorders can take away everything in someone's life, and take away their hobbies, their friends, their interests, everything, all in pursuit of this illness. So what makes it so powerful? We're going to talk about 4 things, but mostly focus on the first, which is the effects of starvation. Then we're going to just touch on what it's like in someone's head to have an eating disorder, and a little bit on the last two. So the effects of starvation are fascinating. We know about this through a study that was done in World War II, where a group of conscientious objectors to the war were allowed to stay back in the United States and be put through a whole bunch of unethical tests. And one of them was this one, where they took these 20 men, and no depression, no anxiety, all these screens. And this is the picture of the men before the study, and then quite dramatically afterwards, this is what they look like. And what they saw in this study was everything you might see on a sort of adult chronic eating disorder unit. So they started to not want to hang out with each other, become very inhibited. They'd eat very slowly and in silence. They were terrified of eating. They started to do odd food behaviors. They became less social. Their thinking was altered. And then they had every emotional side effect in the book. This group of pacifists led to walls being punched in the facility because of starvation. And many had to actually be hospitalized. The next thing is when they were given access to food, they were frightened of it. They had a terrible time actually going through the process of regaining weight and eating again. So what does this tell us? This tells us if someone's quite malnourished, you can't actually diagnose any other mental health illness because it may just be malnutrition. Malnutrition can look like anything. What does it also tell us? Sort of biologically driven, how stuck someone is in starvation and how hard it is to actually get back on track. And we know this as well from studies with mice, where they'll do horrible studies with mice. Anyway, one is they starve them and then they give them access to food or a spinning wheel. And a certain percentage of those mice will not have the food, and they'll get on the spinning wheel and they might run themselves to death. So there is a biological wiring, for whatever reason, when someone is quite malnourished, to move, to be restless, to exercise, and to not take food. And it helps us develop compassion for people because they're so stuck. So that's one of the big take-homes in terms of why it's so hard for folks to get back on track. The next thing is the actual nature of what it's like to have an eating disorder in someone's head. I love this drawing. It looks like Dementors to me, but it's the notion that someone may have like a voice in their head. Some of them will call it a voice. It's the preoccupation that's going over and over and over. Don't eat that, you can't have it, don't have it. And the only way to feel better and not have that voice in your head is to do what it says. And then someone feels better. It's like if any of you folks have worked with someone with OCD, it's the exact same thing. There's germs everywhere, there's germs everywhere, there's germs everywhere. It's a constant preoccupation, and the only way to feel better for a moment is to wash your hands. So very, very similar. And this is an example of what the voice might be saying. Don't eat that, it'll make you fat. People will only like you if you lose weight. And the last one is big at the start of this illness. It acts like a friend. You can trust me, I'm the way to make you happy. This is like, just don't listen to the other people. And it's over and over and over. And somehow that person sort of learns to trust that voice in their head. And over time, that voice can actually become somewhat abusive and critical. You're awful, how could you do that? You're so weak to have eaten, etc. And then again, the only way to feel better, they're driven to feel better, is to have the eating disorder behaviors. The other things that make an eating disorder very severe is over time, the sort of new meaning it develops for this person. And these are examples of things that we've heard over time. Eating disorder is the one thing I'm good at. And this could be someone who's got like trophies lining their wall. For whatever reason, they've never felt good enough. This makes them feel good and powerful. And that's a good feeling, as we all know. Not eating allows me to feel in control of my life. It sort of blocks everything else out. It's the one thing to focus on. Not eating allows all my other worries to go away. Again, this is the one focus-driven. Eating disorder means that you grow up, takes all your hormones away, and all the messiness of hormones. And what we don't like to see is when it becomes an identity. This is who I am. This is what I do. And then the last thing, which could be a whole talk, but I'll give you 2 seconds, is by the very nature of the illness, it's one where there's poor insight, like substance abuse. People, it's just not clicking in the severity and how much it's taking over with sort of what's happening. So combination of all of those things, the voice, the effects of starvation, the meaning, and the poor insight make someone very, very trapped. So the next thing we're going to touch on is, just looking at the time, okay, we can do this, screening. And this is sort of my drumbeat, is screening. What we know is you here on this campus will have a high prevalence. Very few will, few to none maybe, or few will come forward and say, I have this as a problem. It's not something people come in with, but it's something that is slowly destroying their work, their friendships, etc. So screening, especially for clinicians, is essential. And I'm going to give a case example, and you tell me if you've met Emily before. Right on. So Emily's a 19-year-old woman who presents with suicidal ideation, and she's self-harming. And you see her, and she seems to both have depression and anxiety. So a lot of mental health concerns. She's not sleeping, she's starting to drop her credits, and she's spending more and more time in her room. She's been tried on 2 medications for depression and anxiety. They don't seem to be doing anything. And she's seen a counselor for 1 year. Has anyone met Emily before? Yes. So, the thing is, disposition, so how do we help Emily? And the answer to that entirely depends on if you screen for an eating disorder or not. So we'll get back to her in a second, but I'll talk about for those who would be actually asking screening questions, how would you screen? And I'd say it's 2 questions. You just want to screen for extreme concern for weight and shape and the presence of restriction. And if those are negative, then you're done. So it's not a big impact in terms of your initial assessment or meeting someone. And if they're positive, then you're going to want to go through and ask about these things. I should say I'm happy to send in my slides because for our time I don't want to read through all of these, but I'm very happy for our folks to have access to these. So how would you screen for the first 2? I would say, do you worry a lot about weight and appearance? And then the key is how much of the day are those thoughts in your head? And again, you're wanting to get that 24/7. Then are you dieting? Are you losing weight? And then I would get a description, i.e. you're going to start to hear about major food groups being missed or missing major meals, and they're following their weight and they're watching it go down. If those are negative, boom, you can move on. Those are positive, you're like, oh, this is an additional issue. And that's when you're screening for more. You're screening for weight loss. The simple question of have you lost your period is a great one. That's a sign that the body is malnourished. I'm not going to read these, but I will say with binge eating, when you screen for it, we get a lot of people who are binging but are too shameful. It's just awful to say that that's happening. So I always ask it in a way that is like, I'm wondering if something like a binge has ever happened. What happens is someone does not mean for this to happen. It feels totally out of control, and all of a sudden they find themselves going to the kitchen and getting a lot of food. So you're externalizing it from them, and you're explaining why it happens, and it seems to make it more likely for them to say, yeah, that happens to me. And then you're screening for those other things. So if we go back to Emily, so we initially think just anxiety and depression, and when it's screening, we're finding out that this is all this young woman is thinking about. And she's not eating in the morning, she's not having lunch, she has dinner, but then she vomits afterwards. And she's lost 20 pounds over 6 months, and she's lost her period. You don't need to do the calculation per se. She's lost her period and she's had above 15 pounds. you probably know she's in that weight loss, the dangerous weight loss area. So then what do? You're like, oh, now we have a different issue. So let's talk about next steps. The first next step is that I would encourage you to have them see a family physician. I wasn't sure if there were physicians here, so there are some details here, but basically, I guess for everybody, if you have any of these, loss of period, weight loss, or anyone who's purging, they should see a physician. They need blood work done, and they need to have their heart looked at. And so what's our role as a counselor, or as a support person? It's just to encourage them to do that. That may not be a one conversation. That may be we may see this differently, but I'm really worried about you. I'm wondering if you'd consider. And even if you go, it's not like that person is going to alter things. They're just going to check to make sure where things are at and see if they're okay. So you're helping them face fear in terms of that step forward and getting them there. If you like numbers and want to do calculations, you can. So what percentage of weight loss did we have for her? So we'll just go with what she was before, 130, and she's 110 now. So there's that magic number. She's below 85% of where she's supposed to be. And that's a marker that you are shifting gears. We're switching into eating disorder category. So importance of screening. Eating disorders are highly prevalent. So we've talked about the numbers, so 5 to 10% on campus will have some form of eating disorder. Anorexia nervosa also has the highest death or mortality of any mental health. So our numbers are up to 20%. And 20% by suicide, but up to 80% from the medical complications over time. So it's a very lethal illness over time. But the big thing is it's so treatable within the first 3 years. And that's not a precise thing, but generally if it can be caught early, you have the potential, or anyone has the potential of having alter someone's course from treating an eating disorder and having them progress through their life as they otherwise might have, or developing a chronic illness. People can be fully treated. So anorexia nervosa in adolescents, up to 70% full recovery. So major risks and highly treatable, which is why I'm always like, screen. The more we can find these kids and have them treated early, it really can have a profound effect. The other thing about screening is, come back, yes. You can't really treat anything else if there's an eating disorder. So first of all, medications don't work if someone is low weight, as for anorexia specifically. Antidepressants do not work until someone is close to where their body's supposed to be. Their brain is also malnourished or so hardwired thinking somewhere else. Your regular therapy for depression and anxiety is also not going to work. You also risk your alliance not being great because this person is carrying this secret around with them, that talking about anxiety and depression when there's this big thing underneath. So that's another really important reason to screen. And the last thing on screening is just knowing the youth that are at the most risk. So the youth, in terms of the 80% people dying of medical complications, this is the combination. So very low weight, using pills and vomiting as part of their eating disorder, so that's the eating disorder piece. Chronic self-harm or suicide attempts in their history, mixed with some serious substance abuse. All of these hit the heart, and so makes the heart not function as well, and then the low weight means that their heart's not functioning well. All of that puts them at risk of a heart attack. So if you have any youth who have this combination, lots of self-harm, suicide attempts, and substance use that you're finding out about, these are essential to screen because this is a very dangerous cluster. Any questions on screening? Yeah?
Question. Can you, instead of starting with, I understand.
It's just for the people who are watching.
Oh, watching. Oh, sorry. I have, like, starting with substance use disorders. Can that lead, would that, like, when you have incredible weight loss from that, is that an eating disorder, or is that, like, two separate things where eating disorder would result in substance abuse?
Right, so you'd have to work to tease it apart.
Yeah.
We certainly see people who lose weight for other reasons develop eating disorders. Be in a malnourished state, and then their brain gets triggered and starts thinking, I'm too big, I can't eat, etc., just from the initial weight loss. So it would only be an eating disorder if they have that constant thoughts in their head. So you just have to chat with the person to figure it out. Obviously, they're malnourished no matter what, and they're going to have the effects of malnourishment. But whether they have that 24/7 thoughts tells you if it's an eating disorder or not. Okay. All right, so in 10 minutes, we are going to cover treatment. We're going to start with adolescence, which might be an odd choice because your crew are coming at 18 in adolescence. Yes, fair enough, 17, thank you. That being said, the treatment for adolescents is moving into adulthood and for good reason. So I'm going to cover the treatment for adolescents and under the lens for all of you, considering should this person's family be brought in as major partners to help this youth shift forward, and that is the approach in adolescence. So, question for adolescents. Adolescents need at least some motivation to be able to receive treatment. True. False. I don't know. Excellent. So the answer is false. The majority of folks that we see, now I'm seeing a section at a tertiary care hospital, so they're quite unwell. There is little to no motivation, but they don't actually need to speak at all to access services and be fully treated for their eating disorder. And that is done under the heading that, and I'd say anorexia specifically, that they have a life-compromising illness, and we're not saying, okay, that's okay. So in adolescence, I would say, and because coming from other mental health lens, this is a little different, but if you had a 14-year-old at home using crack cocaine every day, we're not going to say to parents, listen, when she's ready, then we're all going to be here to support her. Like, there's not a chance. Those parents would be saying, we are so worried for you, and this is not an option. And they would do whatever they needed to do to remove crack cocaine from that 14-year-old's life. So it's very clear. If you have a 26-year-old who may be in and out of the house, it's less clear. And so that's a little bit of the lens. This is an illness with poor insight and severe consequences. We're not waiting for motivation. So what is the treatment? For anorexia nervosa, it's what's called family-based therapy. And bulimia, which is a little different, is family-based therapy or CBT. We'll talk a little bit about these two. Oh, and medication. Very effective for bulimia. So this is the treatment manual for adolescents with anorexia nervosa. And again, I'm going to talk about it because this is under the heading that you may want to work with the person to connect with their family to access this treatment. So basic principles are the person didn't choose this. They are trapped within their illness. With the family, there's no blame. We start talking about that very outwardly. We're not looking for some horrible thing in your family. There's no one to fault here. And we just accept the person has poor insight and can't make choices for themselves. And then parents are essential. They're part of the team. They're fully informed. And the majority of treatment is done in the family's home. And they come and see a therapist once a week. So what happens, as you can see, it's a picture of a family, including the sibling. This is where the battleground is. This is where all the work is done. The therapy is 6 months to 1 year, done in 3 stages, and the first stage is entirely a focus on weight gain. So you might have parents saying, look, we want to get to the underlying issues, And then it's a little weird as a mental health professional, you're like, we're not talking about underlying issues. We just need to get more food in. She could die from this. We have to get more food in. And so how do we set that up? We do something a bit alarming, which is one, we explain the illness. We say we externalize it. It's not your child's fault. It's not anybody's fault. But we then actively raise anxiety. We will actively say to families, your daughter could die from this if it is not treated. I remember doing this session with a medical student once, and he kind of scolded me afterwards because I made the family cry. But that's a bit of the goal. It feels weird as a mental health professional to do that, but you want the same level of anxiety as if they walked in to get cancer treatment. You wouldn't have to raise anxiety if that's what they were coming in for. It would naturally happen. Their world would stop on a dime, and they would be not at work the next day, they would be organizing. And that's what you want. And when you have that, the parents figure out a way to get that food in. It happens when the therapy works well, which is 50% of the time, they do it. So why on earth do we do that? We could easily hospitalize these youth, and they generally gain weight and they eat, and then they go out and they relapse. And it goes a big revolving door. And when the eating disorder can't exist at home, it can't exist anywhere. And then somehow the byproduct is this attachment piece where you have your parents come in and say, we love you more than anything on the planet, and we're going to do this for you, and our world has stopped until you're better. That has some positive benefits, and they tend to get very well. So that's FBT in 2 minutes. There's no clinicians here, so this doesn't matter. These are the parameters that physicians will use in terms of hospitalization, but low heart rate and weight loss are some of them. Adults with anorexia nervosa, i.e. you can't actively bring in parents, and parents, as I said, now the model is up to 25 if they're at home for sure. But then you're looking to create a team of a physician, a therapist, and a dietitian, and you do want a therapist who has a specialty in this. So within your group, it's hard to access it, so it might be something we're thinking of developing that specialty so that you have a bit of a go-to. And then, as always, family, if it's possible, lots of motivational work, helping them get on a meal plan, to start eating again. Usually it needs a bit of a structured environment, and that's where parents are so helpful. Could be partners, could be aunts, could be someone to provide the intense support to go against your human instinct to start to eat again. All right, I have 4 minutes. I'm going to speed up. Big picture of this slide is you can't do therapy if someone's malnourished. They just don't think, you're not going deep. So you're just supporting, you're showing that you understand this illness, and you're helping them get on track with eating. And there's no medication proven effective. There's some we use, but there's no treatment that way. Bulimia nervosa, you have lots more flexibility in terms of different routes. So family-based when they're younger, but CBT, beautiful evidence for CBT for eating disorders. And if you're trained in CBT, you can pick up the CBT-E manual and start working with it. It's essentially CBT. Dialectical behavioral therapy is also gaining evidence, and that will be the next big heavy hitter. You're wanting to teach someone about this cycle. Sometimes that just helps them have a little bit of something for breakfast and a little bit of something for lunch, and it can break that cycle. That one intervention can be quite powerful. And you want to have them see a physician, and also, as they're going along, you're going to be treating the other things that go along. These are the 2 manuals for adolescents and for young adults. So that's the Fairbairn's manual for CBT. We know that self-help manuals are better than nothing for people with bulimia nervosa, so even as a simple intervention, going to Amazon and getting a bulimia nervosa manual can be effective. And I think that's because they learn about this cycle, and to have a little bit of something for breakfast and a little bit for lunch. And medication is very effective for bulimia, another reason to have them see a physician. I'm not an eating disorder specialist, what can I do? Go back to the notion of screening, back to the notion of having them see a physician, and connecting, understanding, supporting, and motivating them to get the help that they need. And obviously providing reading material. You can discuss with families, obviously with their consent, but really encouraging that consent, that you're to connect with their families, to let them know that their child is in danger. And then these are some of the manuals. These are what are used for the FBT. This one on the right is excellent. It's also excellent for anyone to read because it gives you a sense of what this illness is like. It's an easy pickup book to find what you need. It's not like, I always think it's awful where like, your child is this horrible illness, now read a 300-page book and understand it. But that's not going to happen. This is a faster go-to. It's written by a mother who's an author. It's excellent. So only 2 more slides. This is a great online resource in terms of understanding eating disorders. And these are good ones for adults. You can see the adult one is for the caregiver. So caregivers of all ages supporting people, because you don't get through this illness without intensive support. So no matter what the age, whether it's 15 or 50 or 70, you're building support. Oh, we did it! That's it. So folks have to go. I'm happy to stay to answer questions if other people have some more flexible time.
Just as people are heading out, thank you so much, Dr. Roscoe. You did a wonderful job of bringing us through this. Thank you, IT guys, tech guys. That was wonderful work getting us up and running. Appreciate it. And again, I guess you've got a minute or two. I just want to say thank you. This is just a token, just to say thanks for coming. Thank you, Sarah, for organizing. Pleasure to have Dr. Roscoe from CHEO come. So again, let's just express our appreciation.
Folks have some questions? Yeah.
I've been sort of supporting a family secondhand. A friend of mine.
Yes.
Oh, here we go. So the question that I have for you is this teenage girl, 16, I think, is a dancer. Has, the family is clearly taking action on this, whatever they can. They've been to the doctor, emergency. They're doing everything they can to try to get her to eat. She's skinny as a rail. But the mom told the dance teacher about this, and the dance teacher has said, you're not going to be able to dance anymore until you start eating. And so the question that came back to me sort of through the grapevine is, was that okay? Because now, of course, this young girl is extremely angry with her mother. And, I'm not sure what to answer. I just said, you're sending her a clear message that this is serious. And that, I think, is the positive that I see in that.
And I think this is where, once you have an illness in place, we're not ever holding back on what needs to change. The whole structure needs to change. So if someone's lost a significant amount of weight and isn't actually eating to either maintain or to gain, they wouldn't be, our recommendation would be no dance.
Okay.
Like at all. And in fact, the dance studio could be liable if she were to fall and etc. So
that was my gut feeling, but I just thought, oh, you're here, I will check that out.
Yeah. And if she's really unwell, the physician can see about a referral to CHEO. In the community, Anchor Psychology is the group that has the most expertise. Anchor Psychology.
Anchor, yes.
You need money because it's psychology in the community, so that's not for everybody. And there's months of wait list, but that's where I would recommend.
We're familiar with it.
Yeah.
Thank you.
Yeah.
I was just going to say, on that note, the wait lists are quite long, and so when you have an older individual, not like 60, 67, they have a family.
Yeah.
And they need access to support, and doctors are hard to find. It's a challenge.
It's a huge challenge, and I wish I had an answer. The major thing in eating disorders is, for all other mental health, there's generally, you're looking at 3 levels of care. So there's hospital, which is tertiary, there's primary, but usually there's access to some secondary level of care, even YSB and higher up, etc. We have no secondary level of care for eating disorders. So it is a major gap that needs development and, dare I say, funding and improvement. And it leaves people at a loss. So parents need to, like, if a family needs to figure out as much as they can, and at the very minimum, you're trying to find that team of a physician and a therapist who's going to do their very best to model, or even look for mentorship from folks who are experts in the field to develop the team that you need. But I can't say it's not a major gap.
Just to touch on that, a secondary level where Hopewell is
Yes.
incredible.
Yeah. Yes, actually, that's a great point.
Yeah.
It's a resource for family and patients. It's not treatment per se, but supportive involvement, absolutely. Yeah, it's a good point. Any other questions?
What is the wait list? Like, what is the waiting time for treatment?
It depends on where you're looking.
Yeah.
So the general, if we start tertiary level, I don't know what their wait list is, a few months, but they offer a day program and an inpatient program. So the person needs to be at a fairly significant severity level to be at one of those. They don't have outpatient care. And again, that's a funding issue. So, and they probably are about 3 or 4 months. Most anything is going to be 3 or 4 months. And then anchors more than that. Psychology. There are other individuals in the city for sure, and I'm happy to recommend some names. But most psychology is 3 or 4 months, and it's expensive. So people seem to be getting better plans these days, but that needs a family plan. If an individual on their own, then it's difficult, and that's why, you know, one thing to think about within a structure like a college is it possible to actually get some people trained? Because then you could have it on site. It just needs to almost be developed over time. That's going to have to be the secondary level of care, and we just don't have it right now. Or maybe psychology be covered someday. That's probably wishful thinking. Yeah, it's rotten.
I have a question that's not related to the age group of college kids. What's the correlation between kids that are really picky eaters and the development problem?
It's not a big issue, actually. Kids who are picky eaters generally grow out of it to a certain degree. So young kids, we know for most kids, their taste buds are actually pretty limited, especially around 7 to 10. And then when they go through adolescence, they actually grow new taste buds. And maybe also the peer involvement of, oh, everyone's eating pizza, maybe I should give this a try. But there's no necessarily link to an eating disorder unless there's been weight loss as a result of the picky eating. Yeah. All right. Well, we'll let you go. Thank you very much.
Thank you. Brad, did you want us to?
Yes, if you have the forms, hand them in.
You are awesome. Thank you. You're very much.